Well, thank you everybody, and thank you to Diane for a great presentation. I'm Greg Borowski. I'm the Assistant Managing Editor for Projects and Investigations at the Milwaukee Journal Sentinel. I'm also a Marquette alum and on the board of the O'Brien Fellowship, so that's one reason I'm here. The other reason really is I was fortunate enough to be the editor working with Lillian Thomas on her project, which we co-published with Pittsburgh. And apparently I also owe her below a favor, so that's another reason I'm here this afternoon. This is a panel discussion, and I hope it will be that, just a very good discussion among the folks. This is our great panel here. I'm going to ask some questions first, so I'm going to soften them up a little bit, and then we're going to ask the audience for questions. And we'll keep going until Dan Egan comes in with his tank of Asian carp. So they jump, so be careful. But anyways, I'm going to first introduce the panel. You've all met Diane, who just spoke. Moving down the line is Joy Tapper. Joy has more than 30 years of experience in healthcare policy, planning, and administration. She's currently Executive Director of the Milwaukee Health Care Partnership, which is a public-private consortium that includes the local health systems, community health centers, and top public health officials from the city, county, and the state. And she previously served as Executive Vice President and Chief Administrative Officer for the Wheaton Franciscan Healthcare system. Okay, next to her is Mary Mazul. She's a certified nurse midwife and Director of Population Health Management and Integration for Wheaton Franciscan. In her role, she's helping the organization strengthen its primary care setting to provide population health management. And she's currently a third-year doctoral student at UWM's Zober School of Public Health. And finally, on the end, is Sharon McGowan. So we've got kind of the journalist bookending our panel here. She's editor-in-chief of Milwaukee Neighborhood News Service, an award-winning source for objective professional reporting about Milwaukee's central city neighborhoods. They were integral, you saw before, if you were here, on the diabetes portion that the students put together for Lily's project. She's an instructor in the Diedrich College, has a master's degree from Medill and a bachelor's degree from Washington University in St. Louis, and formerly worked as an investigative reporter and managing editor for the Chicago Reporter. So with those introductions, you can see we've got a great group here. As a journalist, and I spent many years as a reporter before I became an editor, one thing you really want is for people to talk about your work. And not just talk about it, but talk about it in a constructive way. So I think that's really what we're doing today. And I hope this panel will help shed a little more light on some of the issues that Lily brought such great attention to. So the first question, I think we can just go down the line, and then we'll feel free to engage with others if you would like, is thinking about, we heard earlier from John Patton, and we all know there's many other John Pattons out there. Okay, he's representative of folks, but not all that unique, I'm sure, in the city of Milwaukee and around the country. So to help, using with him in mind, and to help frame our discussion, could you each talk a little bit about what is the role in terms of what can we rightly expect from our healthcare system for people like John? And what is his role, or people like him, what is their responsibility? So where is the line for what we can expect the system to do for people, and where does the personal responsibility come in to what they need to do for their own health? Do you want to start, Diane?
Sure. I guess I'll say two things. One, no one can force people to change. No one can make that change occur in another life or another, physical body. So there is personal responsibility, but we often don't understand that things that we think are choices for people are really not viable choices for them, either because of the circumstances of their lives, which hinder them from making healthier choices, or their own personal, emotional, cognitive, spiritual struggles. And so sometimes we have too high of expectations. We come at looking at their lives from our middle class and or educated perspective and think things that look easy to us will be easy for them. And when you're struggling with depression and all of the obstacles in life, nothing is easy. So I think we need more grace, we need more compassion for people than we have. As far as the healthcare system goes, what I've seen, I was in the healthcare system for 20 years and sort of at the cusp of some changes. And so the economics drive behavior in our systems in America. And if we ever want to see the kind of help given to people that is less costly and frankly more powerful, navigators to help people work through the system, community health workers, behavioral health, although I think that's a misnomer because the problem is not the behavioral, it's the emotion and the thinking that drives the behavior, which is perfectly normal if you understand what people are going through. If we ever want to have those things rise in priority, we are going to have to incentivize them by switching the economics so that we're willing to pay as much for those as we are for the super specialists doing advanced procedures and surgeries.
Joy, you've got kind of connection with all sorts of facets of the system here, but where is that line? What's the system responsible for, and what are we as individuals up to and responsible for?
Yeah. Well, I'll speak more. I agree with Diane on the personal side. I think personal responsibility is that we all own that, and that there are significant barriers, particularly for people of color and low-income individuals to move that forward. I'll speak more from where I think is the provider side, the health systems and all providers. First of all, I'm reminded of that great research that's come out of the public health world that talks about 10 to 15% of health is derived from health care. The rest of the 85 to 90% is genetics, environment, and other social determinants of health, environment, et cetera, and behavior. So I think we need to keep in perspective what the health care, or what I call the sick care delivery system, can do. I believe they do play a role, though, and part of that is some of the work that we've been trying to do through this collaborative that's really more focused. Diane's on the front lines. We're working on the system structure policy side of this work. And I would agree, first and foremost, is changing the misaligned economic incentives to be able to deliver the care that people need in a holistic way, in a capitated way, and through what the new language is accountable care delivery systems. I think the other is the promise of primary care medical homes, but real homes, with emphasis on homes. I think we have some of the best clinical care in the nation here in the state of Wisconsin, and particularly in Milwaukee. Great clinical practice. But it's about that wraparound service, those other pieces that really make a primary care health home. And you see those pieces in federally qualified health centers who are organized to do that kind of work in the work that you do and the like. So I think primary care medical homes, I think changing the whole care management system, particularly for Medicaid. We've done a remarkable job in this community and in bringing coverage to individuals. Matter of fact, since April, 40,000 new individuals, childless adults, now have Badger Care coverage, which is a tribute to the hundreds of organizations that were out there identifying individuals and enrolling them. But as everybody said, coverage doesn't equal access. And does not guarantee access. And there's so many dimensions to that. So really working on that. I also support comments about patient navigation. I think of navigating with my own mother, and I know the healthcare delivery system and how difficult it is. Just imagine how that is for people who speak a different language or who may not feel comfortable or trust the delivery system that's available to them. So I'll stop there.
So Mary, from your perspective, I mean, does Wheaton's responsibility begin when John Patton arrives at your doorstep and end when he leaves, or is it something different and broader than that? How do you treat folks like that?
I think that I agree with both what these ladies have said, and I think that we do have to understand. Well, I think today I've heard the term health and healthcare used interchangeably, and they're not the same thing. health is something much more broader than going to an emergency room or going to a clinic. I think as a healthcare system, we are really trying to move into prevention, promotion. We've never been incentivized or paid for that. It is very difficult for us to do. Ideally, our responsibility should somehow that John should know where we are, know how to get to us, we should be able to reach out to John before he has to come to the emergency room. We need to, what we are trying to do and what the healthcare system needs to do, what we know we need to do is get people out of the hospital. The hospital is not healthcare. So equating the closing of hospitals isn't really going to help us with healthcare. Healthcare really needs to occur in the community. It might be in John's home if he's unable to move. It might be in a community center where he lives close to it. It might be in a primary care office. But our responsibility as the healthcare system is to meet the needs of people who come to us seeking that care. And I do think, and what we are trying to do, and I think a lot of the systems are trying to do, is reach out. It's the integration. You know, I asked John earlier, did insurance make all the difference? It made a little difference, but Diane's people made the difference. How do we integrate as a healthcare system with all these community partners so that John feels that wrap around? Because as a community, I will tell you, as a healthcare system, we don't have the resources to take care of the 85% of health. We really only get paid to take care of that 10 to 15%, and we don't really get paid very well. And so how do we integrate with others who are trying to do the work?
So Sharon, from your perspective and having covered these issues and worked with your students on it, what's your take on how well the system is doing in this regard? Do we have a high-performing system in this way, or are there shortcomings and things, or what's your experience been?
Well, first of all, my experience obviously is different from the other people on this panel in that you are in the trenches every day doing this work, and I really admire that. But I think I come to the question from a different perspective. I don't know if any of you saw that yesterday there was a report in the Journal Sentinel about a federal study that came out actually in August, and I don't know exactly what triggered it to come out in the Journal Sentinel yesterday. But what it found is that Wisconsin is number 3 in the country as far as quality health care based on more than 100 different measures. But here's one other thing that it found, and that is that the racial gap not only isn't better year after year as the healthcare system in Wisconsin and the country improves, it's actually worse. And the story quoted somebody, an expert from the University of Wisconsin at Milwaukee, and I'm going to read you one sentence. And I'm not picking on this person, but I think you'll see the point. So he said, you can have a high-performing healthcare system, but still leave some people behind. Mm-hmm. So my perception is that until you accept that you don't and cannot have a high-performing healthcare system, if you're leaving large numbers of people behind based solely on their race, then you're not going to be able to address the disparities. Because unless you know and acknowledge that, you're not going to be able to fix it. So I, as a journalist, of course, our organization can't actually fix anything, but what we do is try to share different perspectives similar to this one. So one more thing, which is that we cover, when I went back to look and see what we covered when I was asked to be on this panel, so I looked at all the stories that are listed under health and wellness. Immunization fairs, awareness fairs about breast cancer, free dental care, Boys and Girls Club bringing together the community for resources. And I thought, what does this actually do to improve health? And what I think, and what I've learned from listening to you all this morning, is it's an injection of help, meaning people can connect to a resource they need, and maybe more importantly, it's an injection of hope, that somebody is trying to plug the dike, somebody is trying to solve the problem, even though it's not going to solve the whole problem of healthcare disparities.
My next question kind of builds off that, actually, and you mentioned before about the many more people who have coverage now under the Affordable Care Act. Can you, and whoever wants to take a stab at it first, feel free, but how has that changed things? Is it a positive, a negative? There's many more people covered, but they're also covered by Medicaid, which we know doesn't, pay as well. I mean, how is that going to affect this issue in terms of positives, negatives, and so forth?
I'm happy to take a start. So just as background, the Milwaukee Health Care Partnership with, again, over 100 organizations worked on and created this consortium called the Milwaukee Enrollment Network, and who was involved in reaching out and enrolling individuals. And I think I go back to this adage, coverage is a gateway to access, but it does not guarantee access. So in terms of, there's two dimensions to this. One is the marketplace enrollment through the Affordable Care Act that allows people to purchase health care with subsidies. And in Milwaukee County, there are about 23,000 individuals who took advantage of that. We don't know how many of those individuals were previously uninsured, how many of those individuals had high deductible, high copay insurance and now took advantage of this plan, or fell off employer-based insurance. So we really don't know what impact and who was covered by that segment. Where, as it relates to poverty in health, this enrollment of 40,000 and growing childless adults, I think, will be significant. But what we did see in April, when all of these individuals received their Forward Health Badger Care card, we saw an increase in emergency department utilization, which we believe, we're still looking at the data, is correlated with individuals who now have a card for coverage, but did not have a way to navigate the system. And they entered the system in the method that they probably knew how to enter the system. So we've been working very closely through our Emergency Department to Medical Home initiative to connect with these people. They receive care at that point of care, but then do health coaching and connect them that very moment with an appointment with a primary care medical home at one of the federally qualified health centers, at one of the health system clinics, at one of the community clinics, AIDS Resource Center, what have you. And then on the other hand, which gets to this connectivity, and I think where the promise is managing the handoffs and the transitions of care. And that is having someone in that medical home who received that appointment call them the day before and say, do you need transportation? How can we get you there? It's demonstrated to improve the show rate by 50%. And then once engaged, really to establish a relationship. Diane, I was really struck by your closing comment. To me, it's all about the relationship. And I think connecting with that individual as a whole person. So delivering the clinical care, but getting those wraparound services, those community health workers, those nurses, those social workers who can do that. Long answer to say, I don't think we know yet. I think it's a step forward. I think as a state, we still have more to do. We could have expanded Badger Care higher and taken the federal bonus payments associated with that. I think we should still consider that as a state because many individuals can't afford the copays or the deductibles with the marketplace coverage.
I would echo that. We have definitely noticed a slight decrease in the uninsured patients coming through St. Joseph's ED. That's our busiest ED in the state. And what the nice thing about getting insurance, what we're trying to do is not utilize the ED for health care. It's a very poor place to get health care. It's not the right place if you have diabetes or congestive heart failure. You need to be managed. What we created in the RED, we have social workers and health coaches and community health workers now that meet people in the emergency room and follow them for about 3 or 4 visits with the primary care providers that we have in the community. But access is an issue, just physical access. Most of our physicians are booked 6-7 weeks out. And that is because, quite frankly, not everybody wants to take care of patients with Medicaid. So we have a hard time finding primary care providers. I don't know if you have a hard time in your work, finding clinics. And then when we talk about access, it's not just about finding a doctor who will see you in 5 weeks. It's about finding someone that you feel comfortable with, someone that understands your social determinants, somebody who can meet your needs, somebody who, when you say I have an appointment at 2, well, that's not going to work for me because I work. Well, our next appointment then is 3 weeks out. That's not really access either. So as a healthcare system, we're trying to, there's a lot of different ways of doing that. Open access scheduling, there are different things that we can apply. But I think one of the other issues is that while we gained a lot of childless adults on Badger Care, we lost some families as well because they didn't hit the federal poverty level that they used to have. You could be 300% poverty level. Now you have to be lower to get Badger Care, unless, of course, you're pregnant. And so we did lose some people. We gained some people. And I think that the Affordable Care Act, we work very hard at Wheaton trying to get people involved, trying to get them enrolled. But some of those deductibles and co-pays are simply too high for some of the families that are applying. And then they choose not to use it because they don't want to pay the price. So it is, it's a double-edged sword. I think it's good in some ways, and I think we still need to work through some of the kinks.
Well, let me refocus, and I'll turn to Diane on this one then. Our system, of course, is based on all sorts of incentives and disincentives and what's paid for and how it's reimbursed. Do we have the incentives in the right spot? I mean, I assume there's no line to reimburse for niceness and kindness and extra time to guide someone over, but how do we rebuild that system so that Diane can be put out of business someday?
Well, the beauty of, and I'm not here, I mean, the Affordable Care Act and the incentives, patient experience is a huge issue. It's going to be an issue for payment eventually. Quality, and this is embarrassing. I've been a nurse midwife for 20 years. We haven't really done a good job measuring quality in our primary care settings. Oh, and now we are. We're measuring it because we know, incentivized, we know that we're going to start getting paid for it. So I think patient experience, that is somewhat of an incentive, but you're right. Who pays for the social worker? Who pays for the health coaches? Who pays for the community health workers and the navigators? There is no financial funding. At the Women's Outpatient Center, we had an urban African American population. We had some of the highest preterm birth rates in the city in St. Joseph's. We created a different way of caring for women over 10 years that decreased the preterm birth rate, and nothing that we did changed medical care. Everything that we did was about perinatal case coordination, social workers, mental health services. We just need mental health services. We did all of that, but a lot of how we got paid for that was the kindness of strangers. It was philanthropy, and it was money that other people brought in. How we change our healthcare reimbursements to recognize that a social worker is just as important as a physician, those are the kinds of things that we need to try to figure out on a higher level, if you will.
So I'm not trying to put you out of business, but we would like you to be put out of business, right? There shouldn't be that yawning gap there, but what's your sense on what needs to be done so that there isn't such a crushing demand on you and your folks like you to fill in these gaps?
The City on the Hill is a part of a free and community clinic collaborative, so there are, 25 or more clinics in the city that provide care, sort of a safety net for people. And overall, the experience since the Affordable Care Act was implemented is that the doctor visits are down as people are finding access to primary care, not just showing up in emergency rooms. And so one of our staff said, well, what does that mean for us? There's only one clinic has closed that I know of. But in our case, that's been the smallest part of what we do is the doctor visits. And knowing what Joy has said to us, we know that's actually the smallest part of solving the problem is the actual medical care. It reminds me of that silly saying, the operation was a success, but the patient died. And if we want the patients to live, we have to do more than improve the effectiveness of the operation once they're under our roofs. And our model is one that's a little different from a lot of the clinics in that we have one nurse practitioner and we use hundreds of volunteers. We have 14 staff members, not because we wouldn't like to have 3 or 4 times that many or don't need that many, but we don't have the resources, and so we have about 100 volunteers for every staff member. That's very challenging for us in terms of raising funds. Thanks to Lily's article, the Journal Sentinel's coverage and so forth, I've gotten a couple of inquiries. A former colleague in the healthcare system who's now has access to lots of resources called me and is interested in helping us raise money. But it's extremely difficult to find the resources to do the work that we're doing that needs to be an adjunct to what's happening in the hospitals and the doctor's offices, to get people there and to get them there at the right times and to provide all of what they need and to address all this underlying stuff in people's lives that takes relationships and time. And so resources are a huge issue. Maybe just one more thing, just in terms of City on a Hill itself. We acquired the former Good Samaritan Hospital buildings on the campus, hundreds of thousands of square feet of space, extremely challenging financial endeavor. And by the time I got there, after the operation had been in existence for 2 years, after the hospital was handed to them, they were $3.5 million in debt, trying to address these problems. And so for those of us who are on the front line and passionate about this, one of the things that I believed we had to do is that's an anchor for us. We need to stay there. And it would be devastating for hundreds of people if we said, this is too inefficient and expensive, we're going to close this down and do something different, because people rely on you being there and they can find you. And there's a trust that comes when you stay put in a place, even though it's difficult, because they have to stay put in that neighborhood and it's very difficult for them. And so we use volunteers, and the gaps sometimes get filled, I'll just say, at great personal sacrifice by some of the individuals who care about what's happening there. And I'm grateful for the resources I accumulated at Aurora that I have tapped regularly at the end of years when there are tens or hundreds of thousands of dollars of gaps between what we've spent and what we brought in.
And I would say, Kev, I just like to say, I don't necessarily think the money has to go to the healthcare systems.
Right.
I think that where Diane is, she knows the population, she knows the community, they trust her. It's more of a relationship. We don't need to have all the health coaches, we don't need to have all the navigators. What we need are strong relationships with those in the community. At the end of the day, your people are far more trusted than perhaps a physician. And that's just the way life is. You're there, it just makes more sense to me that we utilize each other, and it doesn't necessarily mean that all the money has to go to the healthcare system for those types of services. How do we get funding for places like City on the Hill? How do we get funding for our own health department? I mean, our own health department in Milwaukee is poorly funded. There is another place. You asked a question about the healthcare system and the individual, but I also asked healthcare system and our society. What are we willing to do as a community and a society to take care of the people that we need to care for?
Sharon, you had something you wanted to add?
Yeah, I actually wanted to ask a question. I think you mentioned, and you're all talking about this idea of an accountable care organization. I'm curious because in Illinois there's a move to put Medicaid patients into accountable care organizations where basically the organization is paid a certain amount and you figure out how to spend the money. And I was wondering if that's happening in Milwaukee and if that's a good idea.
So there's a number of operational definitions of accountable care systems, but in Medicaid right now in the state of Wisconsin, about 75% of the Medicaid beneficiaries are assigned or enrolled in a managed care organization, MCO or HMO. And the state contracts with those organizations for a couple of things. One is to ensure access to care. They are either to connect or to assign a primary care provider to each of the members. And then also for the management of that care to improve outcomes and reduce costs. And in some parts of the state, those managed care organizations are integrated with the provider network so that all of those resources can be shared. And as you said, funding can be redistributed to community health workers or to social workers or to get air conditioners or what have you, because they have accountability for the whole health of that individual. In southeast Wisconsin, only one of the Medicaid HMOs, Children's, is part of an integrated health system. The rest are independent systems. And we see some misalignment of both economic incentives, but also activities and efforts. In places like Oregon, and I think you mentioned that, they're experimenting with what's called a direct contracting arrangement, where they work directly with providers as part of a whole capitated strategy. And then those provider organizations bring in the social supports and the other supports to really create a system of care for that person.
Work?
I think it's been demonstrated to work. There's a great experiment going on in New Jersey right now for a group of high utilization patients. It's called a Hotspotter Initiative, where they've wrapped around all sorts of health, human services, transportation, criminal justice services around individuals, and have demonstrated better health and at lower costs and lower utilization of the system. But it takes that whole wraparound of care.
And I prepared like 50 questions.
Did you?
We're just going to do the good ones, but I want to give the audience an opportunity to weigh in. So if there's any questions among our group, if not, I'll just keep going with these juicy questions. Any questions from individuals out there? Okay. Yeah, maybe go to the microphone. I think they're recording it.
Is it self-service in the afternoon? Morning, I came to you to either Joy or Mary. Are your institutions, and Joy, you're working with all the hospital systems, and Mary with the Wheaton Franciscans. We know that Medicaid is poor reimbursement across the board when we talk about primary care, specialty care. Have your systems considered, either implemented or considering, providing subsidies so you're able to get patients into non-Medicaid providers so they get some compensation at the level they want, and then they don't come up to your ED or other high-cost facilities?
Thanks for your question, and I think the question is, have healthcare providers considered paying the premiums for individuals to get marketplace or commercial coverage? Is that your question, or subsidy?
That's an alternative. What I'm actually saying is the patient comes into the ED and needs follow-up by a specialist.
Yeah.
You can't buy a specialist to take that patient because, in fact, none of the specialists want to get the Medicaid rates. Are you willing, if you consider, providing a subsidy to say, okay, we'll cover the difference between the Medicaid rate and what you consider your normal reimbursement?
I think because many of the primary care and specialists are increasingly employed by health systems, I think they are doing that already by default. I think they're subsidizing specialists who are serving Medicare and Medicaid patients, where the cost on the dollar is sometimes, I just read a study that Wisconsin has the lowest Medicaid rate proportional to commercial in the nation. So I think they're doing that for their employed specialists who are increasingly part of the delivery system.
Yeah, and I would agree with that. There are we have no providers in the Wheaton system that do not take Medicaid. So unless we don't have that specialty in our system, that's not really, we are sort of subsidizing because we're just sending the patient there and the provider is seeing them.
So there's no longer than the issue that existed at one point in time, was the difficulty of getting a patient into a provider based on access and reimbursements.
Go ahead.
I would say, I can say that in my system. I'm not going to say that for all providers throughout the city of Milwaukee. And there is, how can I say this night? There's a little bit of gaming going on sometimes with that as well. But I can only speak for the system that we work in, and they do take everybody. Now, access, again, is a great question, because if I have a specialist who will see you, but she doesn't have an appointment for 5 weeks, then we've lost our access, even though we're willing to see the patient. I can't, if that provider is the only one that's going to take these patients, they get booked up very quickly. And we don't have as many specialists as maybe some of the larger systems do.
All right. I think that's where we're going to leave it to keep it on schedule. The next step, we're shifting to Dan Egan's project, and the best segue I can give you is that occasionally these giant Asian carp jump out of the water and hit people who have to be hospitalized. So that's where these two intertwine. But I appreciate all of your attention and support. If we could thank the panel again for their input.